observe International Overdose Awareness Day, a day marked not just by remembrance but a call to action, compassion and understanding. We're here to honour the lives lost. We're here to honour the lives impacted and the lives we must strive to protect. Overdose is a critical social, political, public health issue. The stark reality is that overdose deaths are not evenly distributed across our communities. They disproportionately affect different age groups, our First Nations people, those living in regional and rural Australia, and those from socio-economically disadvantaged backgrounds. Men are also overrepresented in these statistics. Unintentional drug-induced deaths were most common among those aged 40 to 49. Nearly half occur in people aged 50 and above. The largest increases in fatal overdose over time are seen among older Australians, with people over 60 accounting for more than 1/3. Among Indigenous Australians, the rate of unintentional drug-induced deaths is alarmingly high, 3 times that of non-Indigenous Australians. Rural and regional Australia has seen a disturbing trend where the rate of overdose now surpasses that of our capital cities. These numbers paint a devastating picture, and I'm sure you've all read in the latest Pennington report that 2,356 Australians lost their lives to drug overdose. This number of lives lost is nearly double the national road toll. This staggering toll amounts to around 67,000 years of life lost, with an average of 32 years lost per death. Each of these numbers is not just a statistic, but it's a person, a mother, a father, a brother, a daughter, a friend, a loved one. Each loss represents a tragedy that echoes through families and leaves a void that can never be filled. These numbers represent a reflection of deep-seated socio-economic inequalities and gaps in our health and social care systems. While the avoidance of overdose deaths should remain our primary goal, we shouldn't also forget about the impact of non-fatal overdoses on the community as well. There are very significant numbers of non-fatal overdose on the community every year, and it's a strong predictor of future overdose and is associated with considerable morbidity. Today, as other speakers have noted, we also confront the rising threat of nitazenes, a potent synthetic opioids that's been having increasing detections in our communities. These numbers continue to grow if we don't take life-saving measures. Overdose deaths touch the lives of so many Australians, yet it is preventable and it's avoidable harm. We have the power to stop it. We can prevent overdose in our communities through a combination of enhanced harm reduction strategies. Yet, around 2% of our federal drug policy funding is allocated towards harm reduction in Australia. First, by increasing access to and availability of naloxone. Under the National Take-Home Naloxone program, naloxone's been made free without prescription in Australia, but it's simply not enough. While that's greatly improved accessibility and removed cost barriers, we need naloxone to be available in as many settings as possible. Recent steps, like the QPS introduction of naloxone, are very welcomed into their first aid kits. I can see Margot smiling at the back there. Sorry about that, Margot. But it needs to be more routinely available. It needs to be available in all emergency settings, in all healthcare settings, in every AOD service, in every homelessness service, across all correctional facilities, in all watch houses, all universities and in all workplaces. In fact, it needs to be part of every first responder and every first aider's toolkit. Greater availability and widespread distribution of naloxone can and will avert future deaths. Secondly, by improving coordination in transitional care for individuals exiting prisons and re-entering the community. Queensland makes up around 25% of the total Australian prison population, and we see around 1,400 prisoners released into the community every month in Queensland. These individuals are at higher risk of overdose, particularly in the first 12 weeks of exiting custodial environments. We need to effectively connect people on pharmacotherapy exiting the correctional system to ODT in the community, both public and private dispensers and prescribers. We need to connect people effectively to Aboriginal community-controlled health organisations, to AOD harm reduction and treatment services, and make sure there's additional social and welfare supports in place. We must improve the transitional care for people exiting prisons and returning to the community. Third, by expanding access to drug checking services. Scaling up drug checking services is a vital step in reducing overdose in the community. The recent permanent policy position of the Queensland Government to implement drug checking services here in Queensland is the right choice. It's the right choice from a health perspective, from a social perspective, an economic perspective, and it's the right choice from a moral and ethical perspective. Despite this, there are still political concerns regarding the future of Queensland's drug checking services with the coming elections. Drug checking services can save lives, particularly in regions like the Gold Coast, which has some of the highest rates of overdose deaths in the country. Faced with the liability of not saving a life, when it could, any government of any political persuasion is obligated to introduce and support drug checking and exercise its duty to prevent harm. We must expand important drug checking services across this state. Fourth, we need to enhance our early warning systems in Queensland and make sure that's integrated across the full service stakeholders. We also must ensure we improve overdose monitoring programs to address the increasing complexity of the drug landscape and provide timely and accurate data to inform effective public health responses, policy making and resource decisions. Fifth, addressing the bottlenecks in community access to opioid dependence treatment. Wider accessibility to opioid dependence treatment is critical. Queensland continues to have the highest patient-to-prescriber ratios compared to the national average. The private ODT system has an over-reliance on high-volume prescribers and little progress has been made towards diversification away from that model. We must diversify the entry points to make treatment accessible. We must prioritise new service models that address the needs of socially and geographically disadvantaged populations. Sixth, by establishing and implementing drug consumption spaces, also known as medically supervised injecting centres, M6 safe injection sites, overdose prevention centres, call it whatever you will. The establishment of drug consumption spaces make for safer environments where people can use drugs under supervision and monitoring, where life-saving measures can be provided at the right time, in the right place, in the event of an overdose. As Tim mentioned, they facilitate access to care and entry points to health and social services. They also can reduce the risk of transmission of bloodborne viruses through providing access to sterile equipment and clean spaces. The evidence of supporting such services in Australia is robust, encompassing health, social and economic benefits. We must start to think about and do implementing safe drug consumption spaces. Finally, there is a need for coordinated action against stigma and drug-related discrimination. Drug use stigma is deeply embedded across society and its institutions. We've seen this through various things such as the Victorian Coronial Inquiry into the death of Veronica Nelson, where drug use stigma and discrimination was found to be so normalised within those institutions that those charged with her care and her social wellbeing while in custody failed. The Queensland Parliamentary Inquiry into the opportunity to improve mental health outcomes for Queenslanders has recommended a public health campaign to reduce stigma and encourage help-seeking and health-offering behaviours. Strategies must target specific audiences and specific systems. They must support, platform and elevate the voices of those with lived and living experience, their families and significant others. Education, anti-stigma and anti-discrimination campaigns and training are required to be tailored and targeted. We need them across various system segments such as media, journalism, healthcare, welfare, social services, criminal justice, corrections, policing, domestic family violence services, child protection system, employment and the general community more broadly. We must stand together to work to reduce stigma and discrimination. Coordinated action is essential. Executing this comprehensive suite of harm reduction strategies will not be easy, but every life saved is the reward. This requires our law and policy makers to make the right decisions, allocate the necessary resources, and act with dedication, courage, and a strong moral and ethical compass. Every life lost to overdose is a catastrophe, and every life saved is a collective victory for our humanity. This day is a reminder that together as a community we do have the power to prevent overdose. Thank you.